Terrific. Thank you both. Good. Well, we have the representative first in line, it looks like.
Thank you. I'm going to mispronounce your name, Dr. Senhava?
Yeah.
Senhava? And I'm going to get to your question. I'm going to give you the background. One of the things that I've been working on in the legislature, off-season and on, is about the problem we have with our healthcare workforce. Georgia's about 37th in the number of doctors for every 100,000 citizens. When you go outside the metropolitan area of Atlanta, we go to 48th, and by 2020 we're predicted to be 50th in the states. So we have a terrible access problem, and we have that same problem with PAs and nurse practitioners. So they're not out there either in our rural areas, and Georgia, believe it or not, is a rural state, and a very large rural state. So, and I'm a little skeptical of CMS. Let me just tell you, I don't mean to be disrespectful, because I was up here for a small meeting with 8 other state leaders, and we were told the way that you thought that by a consultant, that the way they were going to solve the doctor shortage was they were going to have cardiologists and other specialty areas retrain as family practitioners. That came from one of your consultants. I think there'd be a cold day in hell before a cardiologist becomes a family practitioner, but I may be wrong. So, and probably you wouldn't want them anyway, because they chose cardiology for a reason. You wouldn't want their personality as a family. So the question is, when you, and you accepted, you had quite a nice one, but when you did this and made your decision on how you're going to pay, and I think that's a much better way to do it, are there accommodations made for certain areas of the country? Like Georgia has a huge black belt that runs sort of from the Augusta area across our state on down to Alabama. And with that huge black belt becomes a huge problem with diabetes and heart disease and all those problems. Those are rural areas. We have very few physicians. The large portion of their practice is Medicaid, and we're begging any of them in that area to take more or to see them. And we pay them, and you pay them less than it costs to keep their practices open. So is there any accommodation for people that have higher risk or have special problems that are much culturally involved? Because if not, and you think that they're going to have the same results as doctors in the metro area, they're going to fail, they're going to be paid less, and we're going to have even less physicians. Has there been some consideration, and I'm sure we're not the only place in the country that has areas where there's special circumstances?
Yeah, definitely a lot of issues.
Yes.
Well, we've been talking about how you have unintended consequences from your actions, and I'm really afraid, and as you look at an issue, that's what we're talking about modeling, and that's one of the things that you have to do is you look at what possibly might be the unintended consequences.
Right.
And this is one of them. So did y'all take that into consideration?
Yeah.
Obviously.
Yes. Yeah, so I think I'll start with saying that I wish I could fix all the problems, but I think we all have to start somewhere. So I think that what it is that in CMMI and in our group of preventive and population health, we try to do what we can. So I think the problem you're describing, I think they're multi-layered. So the first is the problem of insufficient resources, at least at the provider level. And I'm a pediatric cardiologist, and I always say that cardiac output is stroke volume times heart rate, just as, total cost is price times volume, and ultimately, as you're saying, the total medical throughput is going to be the number of providers times the volume of patients they can see. So clearly there's an issue there. We either need to increase the number of providers or increase the number of visits. Increasing the number of visits doesn't really do a lot of good, so how do we increase the number of providers? And it seems like one of your concerns is that you believe that your state has unique payment challenges that are different than other areas of the state.
In certain areas, right.
Right. So I think that what ultimately this is a question of, at least on the payer side, of one of risk adjustment. And that's sort of the complicated, and, as I'm thinking, how do I systematically think about your question in a constructive way? I think that's the issue, is how do we then make sure that the appropriate amount of payment is given for higher risk patients? And although it sounds like, I don't know who this consultant was who told you, gave you, our plan was to retrain cardiologists to be family care doctors. I think I'm on solid ground when I say that is probably not the policy solution we are going to advance on a national level.
Thank you.
But I do think that this concept of risk adjustment is one, at least I would be happy to sort of talk to you offline about this, but this is a huge area of concern for many, many people. And I think clearly there's going to be some pain as we get there, but I do think that people are working on it.
Well, but what you have to look at, and I'd just like for you to know, many of the people in the rural areas of Georgia, the physicians, are in their late 50s or their early 60s. And they've gotten their kids through school, their homes are paid for, and what they're saying is they're going to quit taking those patients and they're going to go to taking just the ones who can pay them and just work part-time, or they're going to retire. So something that you put into effect may have some problems, but when it does, it may cause us problems that we can't then, once they retire, we can't fix again and makes us even worse. So I think if you're going to model, I would hope that on the federal level, you would look at these issues before you'd implement, because we're having to implement the policies you're suggesting. And we're having to deal with them.
Thanks. David?
Yeah, Dave Kindig from the University of Wisconsin. My gut feeling about this presentation is the two of you ought to get to know each other really well, because both of those together, I think there's a lot of power in where we're trying to go. That's my gut reaction. But for Darshak, so you explained how you're going to start to pay for outcomes, cardiac outcomes, and not specify what the inputs should be. You're just going to look at the outcomes and reward for that. But it's probably true, though, that I don't know what your time frame is going to be, but probably that'll be a relatively short period of time, because for a whole lot of obvious reasons. But there probably are downstream factors that are probably as cost effective, but that require a longer time frame. So my question is, can you, in your group, even begin to think about how, that's a complex predictive modeling equation tied to short-term reimbursements, but also rewards for the downstream fact. Is that even in your scope of view about how you might approach that in the future?
Sure. So I always like to say, if you have any ideas, we're really open to hearing them on this. So please, and I'm actually saying that seriously. But I think that my take on this is that we have to walk before we can run. And it's very important. There is path dependency to some of the decisions we've made, which is that currently we're a fee-for-service system that's just on the beginnings of paying for performance, and that's already extremely controversial. So I think that at least looking at this strategy broadly in this circumscribed way would at least be proof of concept. One of the things we are learning, a painful lesson, is that when we do experiments on somewhat more speculative things, like hypothetically, let's pay for certain nutritional things and exercise and pedometers for older people. There's a variety of ways, and invest in walkable cities. It is highly unlikely that will be actuarially a sound strategy for us up front. Prevention generally doesn't save money, or at least it's hard to show that in the current system we're at. We believe that at least this is the first step, and then perhaps if we can show the proof of concept in this model, which would be several years, maybe we'll get to that area. But thank you.
Paskey?
Sure. I'm Paskey from EPA. So I have a mental model of how the modeling process goes, the life cycle of a model. And when I think about the future of modeling, I think about two personal bellwethers of meaningfulness, one at the end of that life cycle and one near the beginning of that life cycle. And I'll preface this by saying that I'm leaving aside the issue of gathering data, because we could spend an entire roundtable talking about newer ways of monitoring health and the like. I'm leaving that aside. I'm leaving aside the issue of the need to strip identifiers to maintain confidentiality, and I'm leaving aside the middle part of the model life cycle that has to do with model evaluation and establishing model pedigree and provenance. So my two bellwethers that, at least for me, give me an idea of where I personally would like to go in the future. So one is at the very end of the process, at the user end, which is reducing everything to the app level. If I can take these complex models and reduce the conveying of information to the user down to the level of an app, that's my goal. That's the direction I want to go. The second bellwether of meaningfulness is at the start, which I'm calling the MLB test. So, again, as I mentioned, I do baseball modeling. If I go to the MLB site, within minutes, I don't even have to work with anyone. I can download within hours all the information of all the games in the past 5 years because it is written in XML, which is simply geek speak for saying it's in a structured format that describes itself and it is machine readable. As you were talking, Darshak, I went to the CMS data repository, and you don't need to feel bad because I've also been to the FDA Sentinel site, and God knows I've been to EPA's data repositories. And on the government side, every data repository flunks the MLB test, and I can't think why that is. But to me, those two bellwethers are what I use to determine, is this BS or is this meaningful? Are we making meaningful progress towards that future of modeling?
Lots of good questions.
Was I sufficiently
on here.
clear?
Yeah.
Yes?
So your question is, why is the data so bad? Like,
Well, do you agree that
inaccessible.
that's the level and the direction if you want to make modeling as robust and as utilitarian as we would like to be? I would like your comments on whether you are whether those two bellwethers for me similarly resonate with you or not, and if not, why not?
right. Do you want to go first?
This may completely deflect over here, but you know and maybe this is also being kind of a naysayer. I said in our breakout group, I said, is modeling where the friction is? Is that really? I mean, and I don't orient myself around to model or not to model. I think what is the problem we're trying to solve? What's the useful solution? Where does information? Where do gaps in information create friction points in our solution? So I think the test of any kind of information solution model or a diagram or the buckets or anything, is it useful? Does it help people think differently? Does it help people act differently? Do they use it? So I don't know if it has a, I don't think about it in terms of life cycle. So I don't think about it. I don't think about it that way. I think the other thing you said about sort of, data availability. I think there's a lot of encumbrances or barriers to data availability that are limiting ways to use it because we haven't freed it. And I think there are ways to free it. There's ways to free protected health information, linked to other information, de-identified, and creative people will find it and use it and do good things with it.
Right. I think I'll just quickly add to that very briefly that I don't know if you've gone to Blue Cross Blue Shield's website to download their data, because they don't have one. So I think that it's important, again, to put this in the context of how available is broad-based claims information and in what form is it. And in this way, you could argue, yes, CMS has done a poor job of making it, can anybody download it and start to do analysis? Probably not. But I would argue that at least they have taken the steps to start to free up that data. And just as you brought up their criticisms, that will lead to round 2 being a little better. Already, you could argue that numerous people have used CMS data and Medicare Advantage data that's standardized and others to make major sort of pronouncements and policy decisions based on how we should pay for, reimburse, and do public health work. So I agree we have a long way to go. I'm not as pessimistic, but it's a value judgment.
So we're going to take the last 4 questions. Hopefully they'll be brief because we want to get on to some other issues on future directions and capacity building. So Sandy, if you could help us, that would be great.
So, Sandy Magnan from ICSI in Minnesota, and I have a comment and then I have a question. So I'm really excited, Darshak, about this movement towards outcomes. And so my comment or suggestion would be make certain that in doing that with the cardiovascular risk calculator, that we are laying the groundwork for providers to connect, to build those bridges that Rajiv said with community and public health. Because if doctors try to achieve decreasing those risks by more doctor visits, we're going to exacerbate the representative's problem, versus if they try to achieve it by changing the environmental factors as well as doing some things in clinic, then we won't exacerbate the problem the representative had, and I think long-term we'll be more successful in trying to get those cardiovascular risks down. So that's what my one recommendation. My question then is around the accountable health communities, which I'm thrilled to hear about, and I think creating those bridges will create those accountable health communities, and however you can incentivize that. But when several of us created or wrote about that model and coined the term several years ago, in it, we had that you would also incentivize decreasing cost. And as a payer, thinking about decreasing total cost of care, if you can then say some small part of when they decrease that cost has to go back into the community and actually into the social determinants of health. I think you've got the ability, when you incentivize those accountable health communities, not just to work on population health, but to work on total cost of care, which can create that sustainable loop of reinforcement.
Thank you.
Yeah, thank you.
Mary?
I've got,
I'm sorry.
just, yeah, I think I want to make a point. I want to make a point. I think the value of this information, of linking up, let's just say, community risk information and health outcomes, should not be a burden on the health system. I think the collection of that information is something only the health system can do. But the responsibility of fixing those other parts of the social system are really, it's the other parts of our social systems, our food systems, our economic systems, that are not being accountable to the externalities that they have on the health system. So one of the challenges in talking to the health system about considering social determinants of health is they figure, well, then we can't solve this problem, so we're reluctant to even collect the information. So there needs to be a dialogue and a mechanism to send that information should be used to send a signal to the other systems, where it's clear that the other systems have the responsibility for solving these problems that are being borne downstream on health. Thanks.
Mary?
Sure. Mary Pittman, president of the Public Health Institute in California and a member of the Round Table. One thing I haven't heard much today are the wild cards. We're living in an environment where technology and innovations are changing things rapidly. And when you get a model, for example, to address the representative's concerns, I didn't hear anybody say anything about telemedicine and how that could be a technology-related solution that could help ease while you're doing other things. Similarly, if you're trying to engage community, crowdsourcing is being used for so many things. It's a way that you can gather information quickly about something, trying to do the quick and dirty modeling. Can you two talk about how you're, one, thinking about what are some of the wild cards, some of the things that aren't in our models now that we should be projecting? And a second, how do you address getting input through crowdsourcing and other means?
See, I think you're saying, how do you model something that is unmodelable? And I don't have a good answer for that.
Or you're
but-
taking into account the unknown and maybe projecting.
Right, but I think the at least the way we would think about it potentially in the setting we're at, to address these issues of what do you do in these specific states that have unique challenges in other places, is I think we want to build freedom and flexibility into the ways in which we incentivize care. So I think at the grossest form with the cardiac model, it's looking at outcomes. So if you come up with some fancy new technology that somehow reduces the risk of heart attack, whether it's through telemedicine or something else, you will be rewarded for that in some way. A hypothetical example is diabetes prevention. We know that we can substantially reduce the risk of progression of type 2 diabetes in pre-diabetics, but at all ages, including those in the Medicare population. The standard way that's delivered is an in-person, twice-weekly visit for 16 weeks or something like that. Is that really scalable? But what about this new technology that's out there? CDC has remote technologies that are really, really good. And the thing about it is, how do we, as a payer, anticipate that when we model that out? And the way, at least the way I think about it, is that we don't pay for 2 visits per week for 45 minutes each time. We pay for the results. We'll say, look, these are the outcomes we want to have. We want to make sure you complete the program, that you hit these weight loss targets, and you maintain weight loss for a year. So we try to lay out those broad parameters and are non-prescriptive potentially about how you get there. Now, the thing is that sounds really good. There's a lot of freedom. On the back end, there has to be some accountability built into that as well. So I think each of these will be developing over time.
Just on the open source, I think you're absolutely right. We will have abundant new forms of information. The question is, how are population health interests going to help guide what information is being collected? Almost everybody, many people with phones and will be willing to contribute data on their environment. You don't need to collect data from everyone. You need sort of a willing group. Many, I think, clinical interests are already exploiting this technology. Witness, Apple Research, the response to Apple Research Kit. But we need to be thinking about what we want, and how we market, how we get people to start sharing that and creating kind of a portal for that, because the public health side doesn't have the same, idea or use case from the information yet.
George? Yeah, you were up first. I've been trying to keep track of who walked first.
So thank you for both of these excellent presentations. And Rajiv, you made a comment about the social determinants at the individual level, and I think that's a topic that requires further exploration. I'd be interested in what your thinking is there, and maybe not only in terms of what you can say in 2 seconds here as a response to a comment, but I think that will bear some additional exploration. And because the intuitive response of clinicians in practice is they know that. And it'd be nice to be able to really respond to that in terms of thinking about how that can be actionable by them and how they can link to resources, for example, to address that. And then, Darshak, I think your presentation opens an aspect of what we have not explored during this workshop very much. And that's what I'll call the use of modeling in operations. And operations to mean the practice of medicine in a sophisticated sort of large-scale environment. We use a lot of operational models to do just that. So for example, in terms of having data on preventive care for the populations that we serve, we have algorithms and so forth where we can really figure out where the gaps are and how to address them, and then test out ways to reach people and so forth. As you begin to develop your cardiovascular risk app and focus, we've taken an approach over several decades on this same topic in Minnesota, where we thought about the fact that preventive care in a physician's office is a suite of activities that has an evidence base. And you can do the guideline development at ICSI, for example, so you systematically evaluate that evidence and build the algorithm so that each individual doctor doesn't have to do that. And then you can develop the corresponding metric, preventive services up to date, so that you can score that for improvement, or you can score that for public reporting, which we also do in Minnesota, and so forth. And then behind that, it depends upon the government being organized in such a way that it consistently does, convenes the experts to do the science in the kind of rigorous kind of way that the U.S. task force would do. But it's scattered across the government in a very fragmented fashion. So you get the immunization recommendations out of a division of CDC, you've got your population recommendations out of CDC and so forth. You've got childhood recommendations, sort of an orphan, but maybe out of HRSA and so on and so forth. What I'm trying to say is that it would be useful for the government, as you begin to get into these composite measures for which we have more than 2 decades of experience, at least one state, in operations, to begin to think about the larger systems organizations and pressure points. And now you can add on to that, which we're testing with an NIH grant, at the point of care, predictive analytics in terms of cardiovascular risk factors at the point of care, so you can have the conversation with the doctors, and then you can have the apps which then engage the public in terms of what they should expect and how they should have the conversations with the doctor. I think that there's a real opportunity for you folks to really think that through in the larger sense, as opposed to a bundle of, whatever's the primary, emphasis that's going on today. And it's cardiovascular disease for a good reason, but ultimately you ought to think about a different, larger endpoint for the system in the nation.
I'll do the first one first.
I actually lost track of the question. So why don't you go first? Then
You sure? Okay. So I want to I'll make the distinction between the systems use cases and the individual clinical use cases of individual level social determinants data. We're already seeing, I think the physician in the clinic knows who's food insecure, can identify it. I mean, I think we're seeing some good work with screening tools now. We're seeing good work with navigators like health leads to get people to social services. Those are individual use cases. Those don't give us systems knowledge of what the total cost to the system is of food insecurity. What's the total cost on congestive heart failure hospitalizations, of housing instability? The only way we get to the answer to that question is collect the risk factor information systematically on the entire population, both those that are experiencing problems and not. So I think the target audience for this are payers and insurance plans. I think it's something that Medicaid particularly should think about doing, is collecting these risk factors at enrollment and looking at what the loss is, what their spend is, a differential spend is on these various risk factors that we've already identified from epidemiological social determinants research. The use case, in order to get the plans to do it, I think we have to make a convincing argument for how they can use the information. There's clear uses for policymakers and legislators for this information in terms of hopefully reorienting sort of investments upstream. And I think this would be new knowledge to do that. But to get the health plans to collect the information, we have to also find more immediate systems use cases for that. They could use it in predictive modeling for high-risk events. They could use it as supporting care management. They could use it in developing new non-individual programs and solutions for some of the social determinants work. Thank you.
So it sounds like, with the second part of your question, I would say broadly speaking, you're right that there is clinical medicine being done at the population level. So a hospital may look at their inpatient census and say, who are the patients that are highest risk of readmission based on a certain predictive analytics score. We will then target them for special outreach so that they don't become readmitted. That is happening now, and that's a form of predictive analytics. And I think part of it is that by setting sort of broad parameters that incentivize this behavior, we allow that to occur in some way. through an accountable care organization or other forms of accountable care, we also then incentivize hospital system clinicians to sort of take a population-wide look at patients, identify those who are potentially at highest risk of either high spenders or bad outcomes, and then appropriately intervene. That's sort of the broad 30,000-foot policy level decision, and we hesitate to become super prescriptive about everything you're supposed to do, because then you just recapitulate the fee-for-service system. So this is a new way of thinking. Having said that, the second layer of the question is, how do you then get to the personal aspects of decision making, the iPhone app, so to speak, of each patient? And I think that part of it is that within that large ecosystem that I just described, there's still a lot we don't understand and a lot that's not studied. Anybody who's worked in an ACO or capitated environment knows that people are not really thinking about how do we better treat ADHD in the pediatric population. That is not where the big money is. So the issue is, how do we then seed innovation that touches all patients in a variety of different areas? Elderly people who have conditions that sort of lead to quality of life reductions, but don't lead to huge changes in cost and quality. Those are important things we want to focus on as well. And actually, I brought up ADHD in children. I would say pediatric health writ large is something which would be broadly neglected in this framework, because children are a very small piece of that pie. So part of what we're doing through this framework and through our testing authority is saying, well, let's sort of at least start to lay those seeds. And so we give those large systems a specific path, so that then their clinical leaders can go to their CEOs and say, well, hey, this pilot test showed that this way of paying for care, this value-oriented stream, whether it's preventive cardiology or treating ADHD or treating this other condition, this makes financial sense. Why don't we build that into our framework? So I think that's sort of where we hope that innovation could occur as well. I hope that addresses sort of a little bit of the question that was asked.
Great, please.
Hi, my name is Ying Zhang. I'm a research intern at National Association of Community Health Centers. So you talk a lot about social determinants. So for community health centers, they treat mostly uninsured and Medicaid patients who usually don't have resources to manage their chronic conditions, or they don't even have access to nutritious food. So their outcome might not be great because of the low compliance and everything. So is it possible to develop risk adjustment for social determinant in the payment model? And if yes, will it be subject to some ethical arguments saying you are lowering the bar for the poor? And also, I guess I tried to ask, like, is it possible to incorporate social determinant, and how will you go about it? Thank you.
This is a very, very interesting and very thoughtful question. It's an issue we struggle with. And I think I'm just going to add to the complexity of that. The first is that when we adjust for complexity, that means we pay more for complexity. That means we pay less for something else. So part of it is, we could say, yeah, hey, that's a very reasonable policy position to take, but you tell me politically, who are we taking that money away from? And sort of help me navigate that in some way. And not me, but you need to do at the state level. And that is a very difficult battle to fight. I'll just submit that to you, that part of it is that if we're going to give more to somebody, give us a strategy or proposal for who are we going to take that away from on the other side. And the second thing I would say is, while again to add that complexity, please keep in mind that even when money is being given away to half of the United States to take care of these individuals, half the states are not taking it. Why? What is going on? And so while that may really sort of, there's a lot of answers to that question, but these are the kinds of things, and those, I believe that the answer to your question is one that we can develop the models to do that, but I would submit that the major issues there are going to be more political than anything else.
I just want to make one distinction. Just keep in mind the distinction between socioeconomic risk adjustment for provider payments, for taking care of more, for patients with, for lives, I think we're calling it, with greater needs, and risk adjustment on quality outcomes. Those are two very, very different things, and they have different ethical implications. And I might support the former without supporting the latter.
Great. Well, thanks to you both for a very stimulating session.
1 second.
Well, I'm going to give you one chance in just 1 second, Jeff. So thanks so much to both of you. We're going to, we have a few minutes where we can talk about some future considerations and capacity building. I hope, Jeff, your comment relates to some of that.
No,
Okay,
I just,
you have
I just
real
feel
quick.
compelled. This will take 30 seconds.
Okay, real quick.
I think it's incorrect to say that it's a zero-sum game within the Medicaid system, that if you pay more for socially complex patients, that you're going to pay less for others. Medicaid is an entitlement, and so it is not a zero-sum game. And one shouldn't assume that because you're paying more for socially complex patients, that there may not, in the end, be savings from handling that or managing that patient in a better way. So I think it's wrong to assume it's a zero-sum game.
All right. Thanks, Jeff. All right.